just the one piece of advice is just what I always tell myself: if it's meant to be, it'll be, and what's for you will happen. It'll be for you. Hey everybody. Hey, welcome to ep36. Welcome. Happy Monday. Hope you're having a great Monday. Alrighty, we're gonna jump right into it. I'm Rodeline. I'm host of ep36. So unfortunately, our guest, I'm sorry, that's my dog. Unfortunately, our guest that was supposed to come on today had to cancel. I'm sorry about that, guys. But thankfully, she canceled early today, so I had time to put something together for all of you. So it's going to be another emergency medicine case study. I hope you guys are okay with that and not tired of the ER and the antics of the emergency room. Alrighty. I feel like it's kind of a lengthy case study because I have a lot to say about it because it recently happened in my last week or so in New York. So I want to kind of get into it a little earlier, maybe do like 15 minutes of questions and then do the case study. Never tired of the ER. Awesome, because I don't get tired of it either. Alrighty, so if you guys want to ask a few questions, like I said, let's do 15 minutes of questions and then we do the case study and then we answer more questions, or I'm sure you guys are going to have plenty of questions about the case study because I thought it was a pretty cool case study. It took up a lot of my time. I basically didn't even take a break that day because I had a lot of time with that patient, but it was interesting, and I think you guys will learn a lot from this today. So we'll jump right into it, but after answering questions. Anybody want to come on so I can see your face and ask me a question? That would be fun, right? Alrighty, let's see if there's any questions. Any PA questions? How is the job market like right now? It depends on the field that you want to go into, the specialty you want to go into. I feel like as an ER PA, when I first started out of school and looking for an ER job, it felt like there was no jobs at all. But now that I have experience, I feel like there's a lot of jobs. I mean, it's not that there were no jobs that were hired me because I had no experience. But as somebody that has experience, I feel like there's a lot of ER jobs available, just nationwide. As far as a specific location, I don't know. I've had too much of a trouble finding a job in Georgia. As you all may know or may not know, I also work in urgent care. I am not going right back into working. I'm taking a break and focusing on other things. But eventually I may. But I do have an urgent care job, I can go to at any time. When you write LORs, do you add the applicant's CASP ID? No, because that's not how it works. When you want someone to do an LOR, you send their email to CASPA, and CASPA sends them an email to go through a portal. There's actually a portal that CASPA does all their LORs on, and you have to answer specific questions. So I can't just write you an LOR. I can't just write people and somebody asks me to write them an LOR. I really have to know that the person that I'm writing an LOR for, because I like to feel like I know that person. Anything I do is from a genuine space. So, and I like to put passion and put my heart into everything that I do. If you know me, you probably know that by now. So I want to feel genuine. So you go to the portal, answer some questions about that person, saying that you attest this, that, blah, blah. And then you submit the LOR as a PDF or doc or whatever. You upload the LOR. So they already know that applicant. You're going to go under that applicant's file to submit all that information. I don't know if I should have told you guys. Should I apply to any PA school that can't fulfill just one of their courses? I'm not sure what that means. If you don't have the prereq, then don't apply unless you have the prereq. What is one piece of advice you would give your younger self prior to applying? I don't know, because I feel like there's so much that I didn't really know, but what you don't know doesn't hurt you, so I don't feel like it hurt me, because I don't know what advice I would give to my younger self, because I don't know, because the only reason I'm saying that is because by the time that I applied to PA school, I would say, so much failure or so much uncertainty that I was just if this doesn't work out, it doesn't work out. like, I was like, if it's meant to be, it's meant to be. So I didn't have like any regrets or anything. I didn't go into it like, I was nervous, of course, but I didn't go into it like super like, I don't know, like it's hard to say like the whole PA application process to me, because like I said, I was so lost, and I was just like, I'm gonna just do this, and if it happens, it happens. If it don't, it don't. That's where I was in my life at that point. Not that I'm not grateful, not that I don't feel like it was for me. Like I always say, whatever is for you will be for you. But it's just that like the space that I was in at that moment in my life, it was just like going through like a lot of punches in the face, or feeling like life is punching in the face, and then something good happens, and you're like, oh, okay. So I don't know, I guess just the one piece of advice is just what I always tell myself: if it's meant to be, it'll be, and what's for you will happen. It'll be for you. There's nothing you could do or couldn't have done. Well, I mean, there's things you could have done to prevent certain things, but like I said, what's for you is for you. What made you choose PA over becoming a doctor? Because of my lifestyle, mainly. I always answer this question, but because of the lifestyle that being a physician assistant afforded me, it aligned with the person that I was becoming at the time, and aligned with what I wanted for my life. It was just all really personality, my traits, learning about who I am, what I want. Because like I always say this, everybody has the capability to be a doctor. Everybody's smart. Everybody has it. It's just, being able to put that work in, wanting to do it. There's nothing that you can't do. I think everybody's capable of, excelling and, achieving their wildest dreams, whatever you want to do. No one's too dumb for anything. So it's never academics. It's just, how bad do you want it? And I don't really want it that bad. I figured I wanted something that wasn't as time consuming. I wanted to be done with school, and I wanted to just get out there and start working and start making money. For me, it was all about what matched the life that I wanted to live. Did you do a residency? No, I did not do a residency. Are gap years recommended when it comes to PA school? Gap years are fine. There's nothing wrong with gap years. I technically did a gap year. Whatever time you need, however much time you need, go for it, do it. If you need 2-3 years to prepare for PA school, to get those prereqs out the way, to get those classes out the way, to get, shadowing, volunteer work, whatever it is, go for it. Don't let anybody set a timeline for yourself, okay? What you need to do, you're going to get it done at your own pace, because it's you that's going to be completing it. It's you that's going to be paying for school. It's you that's going to be going through school and the stresses of school. So do it when you're ready. How many cycles did you apply? 1 cycle. I got in the first time. Thankfully, thank God. It's not, don't think it's anything I did. Was there anything on CASPA you wish you had known about and prepared for about a year prior? Probably letters of recommendation. Oh yeah, maybe that's something I would tell myself too. Letters of recommendation. Really, that I had a really hard time with that too. Really, finding a mentor, really finding someone that could, of course, write a letter of recommendation, but to me someone that I can connect with and help me through the process. And like for PA school, but just being a PA, like all that comes with, being a young individual, new in my career, not knowing, what the heck I'm doing, having to adjust to all this, especially when I first started in the ER. Boy, oh boy. What advice do you have for someone who didn't get accepted into any programs this cycle? You mean last cycle? Because this cycle's still going on, right? If you didn't get accepted, it's okay. As I always say, look at what point did you not get accepted? Did you get rejected right away? Did you get rejected after an interview? Did you get rejected after submitting your supplementals? Did you get a chance to do supplementals? Just analyze what point that you got rejected, because that'll help you focus on where you need to work. So if you got rejected after the interview, then focus on your interview skills, because they like you enough to bring you on the interview. So it's not more so your stats, but how you presented for the interview. So I would say focus on that. If you got rejected right off the bat, then it could be your stats and your application. So go over that fully. So if you got waitlisted, of course, like I said, it's probably your interview skills and how you presented that day. Or, it's just so many people are applying. You got to make yourself more competitive. Yeah, that's what I can say about someone that didn't get in the first time. Just keep trying. What's meant for you will be. Do you know of any HBCU PA schools? Howard, but I'm not sure if Howard is in good standing right now. How did you get your patient care hours? I was an LPN, a licensed practical nurse. How did you get your letters of recommendation? I got 3 letters of recommendation. one of them was from a PA that I shadowed that summer. So when I found out that I wanted to be a PA, I found out I wanted to be a PA my senior year in high school. And I was like, okay, I got to get all these things out the way in a year. I started shadowing a PA after I graduated, like this summer, like, well, not this summer, but summer time, as I was applying. I shadowed them for like 6 weeks, did what I can, like build a relationship with them as fast as I can, answered questions, made myself look good. And then he wrote me a letter of recommendation after 6 weeks of shadowing him. And I was kind of strategic, like looking back, I was pretty strategic about it. And then my other two letters of recommendation were from nurses. They were actually, but they were my supervisors. So my supervisors from the nursing home that I worked in. One of them was the director of nursing. So she was like the nursing over all the nurses of the whole nursing home. And then one of them was like the manager, the night shift manager or whatever. If you're reapplying, is it bad to use some sentences from your previous personal statement? No. Who can't work during the PA? Do you mean why can't you work? I don't recommend you working because it's such a rigorous program. What do you like most about your work? One of the most things I like about is seeing improvement in my patients, or being able to see improvements in my patients so quickly, and being able to see like the power of stabilization, seeing how like you stabilizing that patient or giving a certain medication or giving this or giving that, how it improves them. Like for instance, like patients that come in with asthma, seeing how they improve throughout the stay. Or, sometimes it's not improving, sometimes it's declining, and then needing to be sent to the ICU or needed to be transferred or whatever. Just kind of seeing the progression of all that and watching it all play out. It's exciting for someone that enjoys, like I always say, putting the pieces of the puzzle together, and someone that's like a problem solver or enjoys, problem solving. That's what I like. Or just like a natural nerd, I guess. And of course, just seeing that, because it's a human being that, someone's life that's in your hands. So, it adds extra stress to it, but being able to see them get better is just like super rewarding and makes you actually feel important. There's the cliche of saying that, we're everyday superheroes and this and that, but sometimes working in the ER, you just see so much like non-ER stuff, and you kind of like question, like, okay, like how not effective, but how useful you are. Like, are you even making a change? Are you even doing that? But then like a patient comes in that is actually sick, and you're like, oh my gosh, I actually helped this person. I actually did something. Like, I actually potentially saved a life. And then you're like, you have that moment like, oh, okay. So yeah, a lot of medicine is like, okay, reassurance. Okay, you're not dying from this. Okay, this is going to be okay. Okay, you can follow up with your doctor. Okay, teaching. And then you have that moment where like a patient is actually sick, especially if you work in fast track or urgent care, but then you have that actual sick patient, and it's like feels so good to see them get better, or see their family tell their family that, this and that's happening, and we're working on this and that. And actually feeling like you're on a one of them shows like House and Grey's Anatomy. Okay, I have a lot of questions. Do you have any financial advice for people? Yes. So that's another reason why I decided to become a PA, because of finances. Not really knowing back then that it would be because of finances. I'm really big on financial stability and making money. Of course, we don't make as much as doctors, but they have so much more responsibility. But as far as financial advice, PA school is very, very expensive. Definitely take your finances serious, especially if you are a non-traditional student, if you have family, if you have kids to take care of, if you have other major responsibilities. Definitely create like a timeline of your financial goals, especially paying off debt. If you care to pay off debt, some people don't. Okay, that's you, but I do. So if you care, create like a plan, get with a financial advisor, get with an accountant. You're going to have to take out student loans. There's no way around it unless you're rich. It's inevitable, and that's okay. If you have to take out student loans to live and for school, do that so you don't have to work, so you can focus entirely on school. That's fine, but have a plan to pay off the loans back within a reasonable time, like 10, 15 years. And that's what I can say. Try to not get too much debt undergrad. Personally, if you can do it, like if you can stay in town in your state for undergrad, do that because you have the residency. You don't have to pay out of state fees. If you can do that, try to minimize undergrad loans as much as you can, because if you have those undergrad loans on top of grad school, it's just gonna like sink you. So what I would say is try to minimize your undergrad loans, because PA school is about $85,000 for me, maybe more expensive now. I don't know. There's also scholarships. I have a surprise for you guys that I can't say yet. Maybe next week or the week after, but there's scholarships available. So yes. All right, I'm going to answer like 2-3 more questions. What month did you apply in the cycle? I applied August 31st, man. Will research experience help with getting into PA school? It may help you depending on what research you did. Did you find anything out? Did you do anything interesting? Did your research get published? So yeah, I think it can help. How do you collaborate with your supervising physician? I collaborate on cases. Like if I have a question to ask, if I have a difficult case, if I want recommendations on something, that's what the collaboration is. Like I'll talk about it in the case I'm about to do. Do you have a good work-life balance? I believe that I do. Was there anything about being a PA that surprised you once you started practicing? I guess that I feel like people don't understand what a PA is. I mean, they probably won't for like years to come, but you really, really are like doing it. Like you really are doing it like yourself, like doing it. Like, I don't know if you guys know what I mean, but like you're really treating patients by yourself, seeing patients, creating treatment plans, like in charge of someone's life. So like, I guess it didn't sink in until I actually started practicing that I'm like, dang, like someone's life is in my hands. Like this is some serious punani. So I guess that's what hit me or surprised me. Like just that feeling like, okay, oh my gosh, like this is the real deal. Practically speaking, how do PAs have less responsibility than doctors? What about their practice makes them have less responsibility? Okay, so yes, I did say that doctors have a lot more responsibility than PAs, but you have to think about the setting, the different specialties. Like for surgery, for instance, a surgeon has to actually perform the surgery. And this is not to undermine what PAs do. I'm a PA, but I understand that I don't have the same level of education as a physician, so I give props where props are due. So, yeah, a surgeon has to perform the surgery, a PA assist. There's a lot more to know when you actually have to perform the surgery, and there's a lot of responsibilities and malpractice. On top of that, like our malpractice coverage is very different from a doctor's malpractice coverage. Like theirs is like way more than a PA's. So that's what I mean by responsibility too. And a lot of times, doctors have to sign off on your charts. We can't practice without a doctor signing off on our charts. Every single chart that we do, a doctor has to sign off. They're basically co-signing. So co-sign means that, oh, yes, I verify, oh, I'm responsible for this. Yes, this and that happened. Like they're saying that if something were to happen, they may also have to take the fall for you. So that's what I mean by the level of responsibility too. Like doctors, you don't ever sign off on all your charts. The doctor has to sign off on your charts as well. So that's what I mean. So they're responsible for their patients, and they're also responsible for the patients that we see as well. So like I said, that's not undermining the physician assistant's work or saying that, we're not responsible. We are responsible. They have to supervise, our charts essentially. Basically, we work very independently, but they have to supervise a lot of what we do. And sometimes that can fall on them. And we consult them as well. And so say also, as far as responsibility goes too, say that something happens, right? Yes. So I was saying that, say I wanted to discharge a patient. I want to admit a patient, but the doctor wants to discharge the patient. Thank you, guys. The doctor will say, oh, discharge. So I document that, discuss with the physician, blah, 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 recommend patient discharge, or blah, 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 this and that. If something were to happen, that would technically fall on the doctor. I did all my documentation. I put the physician's recommendations. So that's what I mean. A lot of times they may have the final say. And if you don't feel comfortable with it, then they can do it themselves. I have actually had a situation, but we're not going to get into that. Okay. Has the patient ever died in your care? How did you deal with it? Thankfully not. I hope that never happens. So I'm going to move on to the case study, guys. The benefits of being a PA rather than an RN. Autonomy. A PA is very different from an RN. A PA, you're diagnosing and treating patients. and you're working very independently, you're a medical provider as a PA. So a PA aligns more with nurse practitioner, not registered nurse. Alrighty, so I'm going to go through the case study now. If we have time at the end, then I will answer any remaining questions. All right, so emergency medicine. If this is your first time tuning in, then you know how the flow goes and what I like. So can you tell me some of the important things about being an ERPA? Have you ever felt that you were too emotional to be in the PA field? No, actually I'm not. I'm pretty not emotional. Okay, sorry guys. Yes, Sarah, yes. Words, always think about that. Yes, speaking like Rodeline's pupils. All right. Awesome, guys. So you're going to always have to remember words first when practicing in the ER. Always, whatever the patient comes in with, you got to think about what's going to kill your patient. Are they sick? Do they look sick? Is it going to be a possible discharge or admission? You're going to constantly be thinking about that. Of course, you won't know and don't have to know right away, but you're going to eventually have to know once it's time to discharge or admit. Okay? Or transfer, who knows? So, and then remember some pearls, your differential diagnosis. Start thinking of some differentials. From the chief complaint, you're going to be thinking of differentials. And then when you see the patient, when you do your history, your physical, all of those are things that's going to be going on throughout the ED course. So, by looking at this picture, does anybody have an idea what is going on? Anybody want to come on to do the case study with me? I promise this is fun. So Hale, I think that's your name. I hope I'm pronouncing it right. Good job, guys. Yes, guys. Yes. So a 42-year-old male presents to the ER with complaint of vomiting, blood, and abdominal pain. So, yes, he has this big belly. I mean, okay, my patient is kind of exaggerating. My patient did have a big belly, but his was not that big. His was not like that distended, and he was not that skinny. But you will see, especially in certain populations, like I didn't see ascites in Georgia as much as I saw it in New York, okay? And as much as I saw it in the area that I was in, and it's just due to that population, to that area. A lot of alcoholics, a lot of drug abuse. I saw so many ascites cases, so many patients that look just like that. Some of them were worse. So I know it does look like kwashiorkor, but it's not. It's ascites. This acidic or ascites is due to protein dysfunction and whatever, and fluid imbalance and all this stuff, this pathophysiology that I don't really remember from PA school. Yes, ascites is due to alcoholic cirrhosis. Well, it's not the only cause of ascites, but yes. Yes, Ebony Carter, good job. Kudos to you. You're already solving this mystery. All right, so the vitals, stable or unstable based on the patient's vitals. Stable or unstable. Quick. On your feet. Stable or unstable. Yes, Aria, dang, y'all are smarter than me. I was not this smart, like, when I was in PA school. Somebody said lack of albumin. Duh, yeah, I said protein, but y'all saying albumin, okay? Yes, okay, the vitals tell you the patient's stable, right? The vitals are pretty stable. He's not febrile, he's not tachycardic, he's slightly, but he's not. Blood pressure is, on the lower end, but still okay, may need some fluids. Respiratory rate is great, oxygen is great, okay? So even though he comes in with vomiting, blood, and abdominal pain, his vitals are okay. So this patient is not like, dire yet, but you don't know what's going to happen, right? The ER, anything can happen. So I'm sorry. Did I change my tone of talking? I feel like I just got excited all of a sudden because I am. You guys are so people talking about check his places. Dang, y'all are so smart. How do you guys? I didn't even know all this stuff about the liver. Dang. So we're gonna get into that, y'all. Okay. So dang. So this guy comes in with this complaint and he's vomiting blood. Okay. So you go to see him, and so what do you want to ask? What's gonna be in your HPI and then your physical? What are you gonna do? What are some important questions to ask? Of course, you're going to ask questions, but what are key questions to ask about this possible diagnosis? No, people are telling me all these tests you're going to order, we're not there yet. Don't jump the gun, okay? Stop being so smart. Okay, we're talking about your HPI right now. Yes, alcohol, drug and alcohol use. Yes. So of course you don't want that to be your first question, because you don't want, the patient to think that you're judging them or whatever. So of course, reel it in. Yes. How long has this been happening? Has this happened before? Substance use. Yes. So an important question is, you've been vomiting blood. How many times have you vomited? When did this start? How much are you vomiting? Sometimes I ask for a picture. Sometimes how they feel, because they're vomiting blood, they may feel weak. They may have chest pain because they're losing oxygen. They're losing fluids. They may have chest pain. They may feel short of breath. Those are not related to GI, but they're going to affect other body systems, right? So you ask all these, and that also tells you if they're stable or unstable, or how they may decline, or their risk of declining or decompensating. So you ask those important questions. Yeah, the color of the blood. Then you ask about abdominal pain. He's having abdominal pain. Where is the pain? How long have you had the pain? Any diarrhea with the pain? Any blood in the diarrhea? Because he's vomiting blood now. Vomiting blood is upper GI bleed. But if he's diarrhea, it may be a lower GI bleed. If it may be both. Who knows? Okay, so yes, you could ask about alcohol intake. Are you currently drinking? How much do you drink? Have you ever had seizures? Is this person going to have to be on seizure precautions? Have you ever had delirium tremens? So those are all things to ask, important questions to ask. Yes. Medications use. Yes, medications can cause that too. Blood thinners. Yes. Oh my gosh, y'all are so smart. Y'all can already, everybody goes to PA school. Blood clots, not necessarily. Blood clots would be the opposite. But when you have liver dysfunction, you could be throwing, your body's, if you're breaking down, if you're bleeding, then your body's going to try to clot. So it makes sense, but I understand what you see there. But okay, this patient, so I went to see him, asked him a lot of the questions that you guys asked, and being that he's vomiting blood, I thought, okay, he's gonna need some fluids, right? But then he has this ascites, and he's at risk of fluid overload. So, and I hate that. I hate when I have patients that are like that, like they're vomiting, but then they have history of heart failure. They look super dehydrated, but then you got to figure out, like, okay, strict little bit of fluids, but strict fluids or fluid mix. I always like to ask the doctor about fluid resuscitation in patients, complicated patients like that. But I did start him on some fluids. And then what do you want to give now? Okay, never mind. Before we go into that, past medical history. So he told me that he told me, I think, just hypertension. He was Spanish speaking, and I did try to, I use a translator. We have a translator phone. But there was still like some kind of language barrier, I felt like, and I learned that a lot of areas in like South America or Central America, they have different dialects. So the translator may not even understand like that specific dialect sometimes. But yeah, I understood him for the most part. When I asked him about alcohol, he told me he drank 2 beers, but he didn't really say whether he like has a history of excessive drinking or alcoholism. So I figured that's what it was, because he said he used to drink more but drinks less. So that's basically part of his medical history. I don't think he had any past surgical family history. None of that was really important. He didn't use any drugs. So systems you want to assess: GI, heart, and lungs. For GI, the physical, of course, you see the ascites, the acidic belly. What are some other things that you may notice doing a physical on this guy? What are some things you may notice when doing a physical? Okay, you notice this big belly. When you feel his belly, what might you feel? Guarding, and a good job. Yes, guarding. Yes, so hell, dang girl. Hard and abdominal areas. Yes, you may feel the liver. It might feel enlarged. Pallor. Yes. What might you see in the eyes or the skin? What might you see? What color? Think of bad liver. Yes, Maria. Jaundice. Y'all are so smart. Yes, we're going to learn about the liver today and all the important functionalities of the liver. Listen, when your liver is messed up, you guys don't understand how important the liver is. It's like such an important organ. All these organs are important, but the liver, man, you're going to see it when the liver's not well. Like I feel like you don't really see it when the heart's not well. You don't really see when the brain's not well until you have a heart attack. But like the liver is like one of those things, like you can see the long-term effects of it. Okay, so yes, jaundice, you're going to have the big belly. You may have caput medusa, which is like the big dilated veins on the belly. You may feel a large liver. So this is why all like the history is, the physical is important. So yeah, and this guy had all of that. Bilirubin levels, yeah, that's going to be next in the labs. Okay, but y'all are so smart. So, so I did this. I did my physical. I went back and I sat down, started ordering some tests on this guy, right? So you start ordering some tests on this guy. So we order some tests. We order our basic CBC, CMP, lipase, urine. But what specifically is important for this patient? A lot of you guys were saying some of this. So somebody said bilirubin. The bilirubin is going to show up on the CMP, or you can do an LFT, liver function test, that shows all your liver functions. Yes, good job, liver function test, as I said. So what are some tests that are specifically important for this person? Yes, lipase, we said that, but I didn't mention it here, but I want you guys to tell me. Liver enzymes are there. Okay, think about what the liver does. Platelet count. Awesome. Yeah, yes, but that's going to be on your CBC. Think about platelets too. Ebony, awesome. It's not here. I didn't list it here. What I want you guys to tell me. I didn't list it on this slide. I want you to tell me. Yeah, sugar is important, but it's not. Toxicology, yeah. Drug screen, sure, yes. Hemoglobin, yes, that's in the CBC. So it's not here. Okay, hold on. Insulin, not quite. Leukocytes, that's in the CBC. Blood alcohol, that's that's good. I would order that. Albumin, yes, that's good. That's going to be on the CMP. AST, those are all blood clotting ability. Yes, so hell, hold up. Are you a doctor? Okay, so hell, yes, blood clotting factors. So the liver makes clotting factors. And so what's going to help us determine clotting times are the PTT, PTINR. So that's what we have to do to assess how the liver is functioning. Are you clotting? Are you bleeding out? Are the bleeding times extended? Like, is it taking you long to form a clot? Yes, PTT, PTINR, coags. Yes, that's what they're called. Yes, guys, yes. What's another test? I didn't order this test because it's non-specific, but what's another test you can order? I did order coags, but this test I'm talking about is another test that you can order. What's another test? Yes, so Hale is on a roll. Yes, Liam Cortez, awesome. Ebony, yes. Luke, I'm gonna have Luke speak afterwards. Okay, CRP, lipid, not right away, not in the ER. So another test you can order is ammonia levels for hepatic encephalopathy. But ammonia is, if you suspect hepatic encephalopathy, like if they're disoriented, if he's not alert oriented, blah, 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 if he looks unwell. But I wouldn't order ammonia levels unless he looks like he could have hepatic encephalopathy. Yes, lactic acid. You can order lactic acid because these people can be at risk of infection. He could have spontaneous bacterial peritonitis. Let's see. Let me see what I missed. Troponin. I ordered a troponin. Remember, anybody over the age of 30 typically complain of abdominal pain, especially non-localized or upper abdominal pain. You want to order troponin. You want to order EKG to make sure everything's okay. You want to order a chest x-ray, rule out any cardiac ACS that could be going on along with that. So let's see. I think we got everything. Oh, what's one important thing for this patient? If somebody says coming and complaining of bleeding, vomiting blood, what should you order in preparation for? Remember, this is the ER. What do you need to be thinking about? What should you order? What do you need to be thinking about? This is the ER, emergency room. Quick. What should you be thinking about, guys? Type and screen. Yes. Oh my gosh. Yes. Y'all are so smart. I'm so proud of you guys. Like, I would never ever know this stuff. Yes, you want to order a type and screen, okay? You want to know the patient's blood, okay? You want to order a type and screen. So that's one of the tests that I ordered right away as well, because the patient may need a blood transfusion. They may have a hemoglobin of 6.5. Yes, type and screen. Who said that first? Roy, yes. superstar. Y'all are so smart. Like, oh my gosh. You guys could have, dang, y'all probably would have done better than me on this case. Oh my gosh. All right. Somebody said pink and red tube. Girl, yes. Pink tube for the typing screen. Yeah. And then who knows what tube color is for the coags. You know, there's a national shortage of this tube. I don't know why, but there is. Okay, but what tube color are the coags? Michelle, since you want to be so smart. Yes, Haley, a blue. Yes, y'all are so smart. Blue, it's blue. It's like a baby blue. Yes, all right, moving on. Listen, I make learning fun. Y'all never gonna forget this. But I'm so proud of you guys. The amount of answers that you guys are answering correctly. Like, okay, so what imaging test is especially important to order for this patient? Wait, no, okay, before we get there, let me tell y'all what happened. Let me tell you guys how the ER can just like this. So I went to my desk, whatever. I talked to the patient, ordered all of these things that you mentioned, and I forgot to ask him a question. I forgot what I forgot to ask him, but I went back. And this guy is like, I went back also because I was scared that I was giving him too much fluid. So I went to like adjust his IV. So I went back and he told me that he vomited. And I looked and his basin was like full of blood, y'all. I'm like, I'm like, oh no. You going, you leaving, you going to the critical care side. So like, I've never seen so much blood in my life. Like he literally vomited all this blood in this basin. Like, you know what, like the gray basins that they, like, it's like the size of this monitor or almost the size of this monitor that they give you. Maybe I'm exaggerating a little bit. It's probably the size of this mouse, the length, I don't know. But he vomited all up in that basin. It was like full. And I'm like, no. And it was nothing but blood. No, at this point, you may, even though your vitals look fine, I don't want you to decomp on me. So I'm taking you to the critical care side. Like our ER has a critical care unit where they're monitored very closely, and they're on the monitor. The nurses watch them, like right there. It's like 2 nurses and for 4 patients. I think, but either way, I transferred him there like right away, and then I went to tell the doctor immediately. What are some immediate things that I had to do after I saw that? What are some immediate things I had to do? No, it's not alcohol poisoning. It could happen, but his blood alcohol was 0. Okay, what are some immediate things that I had to do because this patient is actively vomiting blood? Yes, Kimberly, blood transfusion, yes. What are some other things I had to do? Yes, Haley, yes, he would need a surgery or a procedure. But before I can do that, who would I have to contact for that? What are some things I'm going to have to do? This guy is vomiting right away. What do you want to do? Not vasopressors. Remember, his vitals are fine. Yes, Ebony. Oh, okay, Ebony. I really want to know what some of you guys do. I feel like, dang, was I stupid back in the day? Because I wouldn't have known any of this. I really want to know how you guys are doing. Like, I don't know. How do you guys know all this already? Okay, so yes, Ebony. So I had to call GI right away. Got some orders from GI. Of course, I already ordered labs on this patient. I forgot to tell you guys what's a medication that you want to give the patient. I forgot to go over meds, so we went over labs. So what's a medication that you want to give the patient? Dang, somebody said anatomy classes. Dang, so I really was not paying attention in anatomy. Let me tell you, you guys, I was really studying and like dumping information out until I got to PA school. I'm so glad I'm a good PA because I started taking my education serious. But okay, I'm sorry, I'm a joke. Yes, so you want to give anti-nausea medicine to stop that. I ended up giving him Zofran, Reglan eventually worked. But what do you want to give for the bleeding that can help manage it? For GI bleeds, think of GI bleeds. What do they immediately give for GI bleeds? No, not Lasix. Vitamin K, yes. Hadil, yes, for clotting. Heparin, no. Heparin, no. Heparin's gonna make it worse. No, Octreotide. First of all, Roy, how do you remember that? I did remember Octreotide from, I think, anatomy and physiology. No, heparin's the opposite. Heparin will make you bleed worse. No. Yes, vitamin K to promote clotting. Remember, this patient is bleeding. Heparin makes you bleed. Tagamet, no. Eventually, he may be on Tagamet, but what do you want to give IV like right away? Dang, that's why you're so smart. A flight paramedic. Okay. What do you want to give right away IV? Well, think about it. Think about it. P starts with a P. What do you want to give right away IV? Come on, guys. P. Potassium? No. Not potassium. That's an electrolyte. Come on. What do you want to give? P. Proton pump. Yes, Dominica. PPI. Proton pump inhibitor. Protonics. IV protonics. Yes, you're going to give that. The proton pump that causes all that acid. All right. So, yes, those some of the medications that I started him on were IV fluids, PPIs, protonics, bolus, and then a drip. I said Zofran, and he also got Reglan. And then when I saw that, like I said, I transferred him to the critical care. And then I told the doctor, he said, get GI on board. I called GI. I also ordered some blood for him, 2 units of packed red blood cells. Of course, got consent for all of that. Of course, his type and screen was already running on processing. So mind you, I mean, because I ordered all these labs already, the medications were all that I really had to give. So I called GI. GI gave me some more orders. Of course, they told me Octreotide. I was going to order Octreotide, but I didn't really know like the dosing and all that, and they gave me all that. Octreotide is, you'll see all that. It's a hormone that they give. It helps to control the bleeding. I don't know the full mechanism of action of it, but I know that you got to give it to, for what this patient has. So yeah, Octreotide. He also got fresh frozen plasma along with the packed red blood cells. Fresh frozen plasma helps with clotting. Let me see what else the GI said. Of course, NPO. NPO means nothing by mouth. Let me see what else GI said. And he was going to get an endoscopy in the morning, and then he was going to be admitted to the ICU. No, I did not give Zofran and Reglan at the same time. I first gave Zofran, and then he was still vomiting like a lot of blood, and then I gave Reglan, and then it helped. I found that Reglan is kind of more effective than Zofran. At first, I didn't really like Reglan because of the like psych type of side effects, but I haven't had any patients really had a psych like adverse effects from it. Yes, you guys are doing amazing with this. Like, I'm so happy. Like, oh my gosh, I wish I could teach you guys all the time. This patient got the meds. He's on the monitor. He's in the critical care side, waiting to, I spoke with the attending. I called the admitting physician in the ICU. They were going to come down to see him. So the only thing that was pending, and all these meds were pending for the nurse to give it to him. I kept checking on him, making sure that he didn't destabilize or that he was fine. He remained relatively stable. Of course, he's still like critical because he's literally vomiting a lot of blood. But for the most part, thankfully, he was stable. Like, he was alert. He was talking to me. He said he was feeling a little better. His vitals were fine. So that was all good. All right. So what imaging test is especially important to order for this patient? What imaging test is especially important to order for this patient? What imaging? Of course, we're going to order a chest x-ray. Chest x-ray is fine. But what imaging test is specific? Yes, Ebony, abdominal CT. Okay, Ebony, what do you do? Okay, ultrasound's okay, but CT is going to show you a lot more. CT, yes. So you will want to do a CT with contrast. If the patient's liver function, if the patient's kidney function is not good, then you will order without contrast. But you can order abdomen pelvis with contrast. And what do you guys see here? What is all this junk in the trunk? What do you guys see? What's that arrow is pointing to? Okay, so he does have a fatty liver. I mean, it's cirrhotic. Look how weird in shape and all these bumpy looking things, scarring. Yeah, but what is this right here? This gray stuff on CT. Fluid, Amber, yes, fluid, Amber Martinez, good. That's all the ascites fluid. So this guy, it said massive ascites. The radiologist interpreted it as massive ascites with some portal hypertension. So this guy had massive ascites and portal hypertension. So with that coupled together, what do you think is causing his bleeding? Yes, this is all fluid pushing on organs. So what if you have portal hypertension that's causing ascites? What else could it be causing that's likely making this guy bleed? Yes, Christine. Oh my gosh! Ding 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 ding. Yes, girl. You go, girl. Yes. Oh, shoot. I didn't mean that. My bad, y'all. I forgot to change this. It's not pregnant and bleeding. It's man and bleeding. Okay. Yes, yes. Good job, guys. Good job, Roy. So this guy has cirrhosis of the liver. Dang, I was so ready to show. I always forget to change my PowerPoints. Okay. All right. So this guy has cirrhosis of the liver. Cirrhosis of the liver results from, chronic alcohol use. The most common cause is alcoholism. So watch your drinking, y'all, this weekend or this past weekend, 4th of July. So you're worried about the complications of that and the long-term effects of that. The main thing is portal hypertension. There's this spiel, I'm sure you guys know about it from your anatomy and physiology class, about the portal circulation and the benefits and significance of the liver, and how when it's cirrhotic or hardened fibrose, it's going to affect that. It's going to increase the portal tension or hypertension, blood pressure going in the veins, and cause an array of things like ascites, like varices, like jaundice, like jaundice is, the result of the liver not functioning as it should, as far as the breakdown of bile and bilirubin, and caput medusa, coagulopathies, because the liver is important for clotting factors. So all the things that you have learned or will learn about the functionalities of the liver, when it's dysfunction, then you'll see all these things. And it's amazing because you'll see it on the patient. Like I said, that's like one of the only disease processes that you'll actually see it. Like you won't see hypertension until a patient has like a stroke. You won't see diabetes until somebody has a foot ulcer and a A1C of 10. But you'll see like the effects of cirrhosis of the liver, and you'll see it chronically. Like they'll walk around with ascites and they'll be fine. They'll walk around with jaundice and they'll be fine. I'm not going to say fine, but at baseline. So yes, so it's such an interesting, organ. I think it's one of my favorites now. So good job, guys. Good job. So let me tell you about what happened with this patient. So of course, as I said, this patient was admitted. He was not only admitted, but he was admitted to the ICU because he has esophageal varices. So it's a long and complicated explanation. It has to do with the portal hypertension, and you have these little veins in your esophagus that start bleeding because of the high pressure. They're getting a high pressure of blood that they're not typically supposed to, and they bleed, and you're going to start vomiting. They can bleed out. It causes hemodynamic instability and can lead to death. So you prompt treatment of this. So the patient is going to eventually need a endoscopy, which he had the next morning. That's why he was NPO. And when I got back to work the next day, it did say that they found like 8 bleeding varices. I don't remember what they did. I don't know if they did a ligation or what, but yes. So this is what happens, or this is what happened to my patient. I hope you guys know all of this. I'm sure you don't know. It's okay if you don't know it. You'll learn all of this. Let me see. All of these, as I said, are complications. This is not all the stuff that's listed. This is like the most common things you'll see. But you'll have the little telangiectasias. I hope I'm pronouncing it right. You'll have, like I said, hepatic encephalopathy. So you see how the liver looks so fibrosed and bumpy and weird? Yeah, that's what happens with cirrhosis of the liver. All right. So this is just a rundown of everything that happened from the minute that the patient came in to the minute that the patient is discharged. I actually had another case, but and she was vomiting like this too. And it was the same thing, like strict and quick prompt treatment. So with a patient like this, stable, unstable, stable versus unstable. Always be thinking about that. Always be quick. They're bleeding. They can bottom out really quick. Prompt GI consultation. So as soon as I saw that bleeding, I was going to consult GI either way, but I just did it quicker than I would have. I didn't really wait for labs and stuff to start coming back. I called them right away, tell them, okay, this and this is going on. We got to prepare for this. We got to do this, that. So they said to keep him in PO. The patient was on a cardiac monitor. He had some IV fluids. Like I said, he has this fluid imbalance and metabolic imbalance. So you got to be properly monitored when I'm giving him the fluids. You don't want him to go into fluid overload. And then he got a blood transfusion. He got 2 units of packed red blood cells and I think 1 unit of FFP, but also got vitamin K. He also got octreotide. Octreotide is a cancer drug, I believe. It's a hormone, but it decreases inflow of blood to the portal system. I had to Google that. I did not remember. I know that it's given, but I didn't remember like the mechanism of action. And then, of course, anti-nausea medicine. The patient also got prophylactic antibiotics and pain medicine. The patient was admitted to the ICU and had an endoscopy the next morning. This was in the middle of the night, so he had an endoscopy like a few hours later. So, true emergency. So this is what I meant by like, you'll see like all these reassurance cases where like you're telling the patient, okay, you know, you're okay, this is gonna be okay, discharge. And then you'll get like true emergencies where like you feel like, oh my gosh, I saved this patient, I saved somebody. And that was just one of the cases. And I just loved how like, even though I didn't really like take a break and I was just like constantly checking on the patient, I just love it. I love it when it gets like that. Of course, not at the expense of a patient, but just knowing that, you know, you really saved and impacted somebody. And I hope he's doing better. So as I always say, know what's common, know zebras, know what's going to kill your patient. Okay? This patient was not bleeding or because he had a long night of drinking. He was bleeding because it's a true emergency. Or he's not bleeding because he, I don't know, bit his tongue. Okay? So true emergencies. Alrighty, guys. I hope you enjoyed that. As always, contact information, Instagram, email. Did you say you worked with your supervising physician on this case? A little bit, kind of. He told me a few things to order, but I mean, I knew to order them, but with cases like this, yeah, I would tell my supervising physician. But yeah, I did. I told him, but he wasn't like, it wasn't like, oh, he was documenting or checking on me or, you know, like over my head or anything. Okay. Yes. Okay. All right. So yeah, I mean, I was completely basically by myself with this case, just like you'll be in a few years. And listen, y'all really, really impressed me. I was just like, how do you guys know this? I was so excited to like explain things that I didn't really even have to because you guys already knew everything. So good job. Kudos to all of you for being so smart. You guys seem very well prepared for a PA school. I'm glad you guys like this case. I guess it's okay that the person canceled. I'm still going to try to get you guys more people to come, but I actually like, maybe I haven't because I actually like, you know, talking to you guys and presenting my case studies. But yeah. Alrighty, I hope you guys learned from this. Yes, of course, you can DM me, you can ask me anything. If you have, you know, further follow-up questions, then of course, feel free to ask me. Here, this is my Instagram, my email. Oh my gosh, I'm so glad you learned. That's the point, yes. Even though I was just a joke. I try to make it fun, I don't know. Okay, this person that messaged me, email me. If you have personal questions, email me. I'm glad you guys learned. Don't forget esophageal varices and portal hypertension. And don't forget caput medusa and ascites. I should have talked about paracentesis and ascites. So ascites, people walk around with them. Like you walk around, like they don't really do anything unless it's affecting your breathing. You need to do a symptomatic tab to just kind of help you feel better. Or if you suspect an infection from the ascites. Or if your liver, like if you have like an acute on chronic liver failure, if like, you know, if you're decompensated and you're really sick and you need to get a tap and yeah. But a lot of you just walk around with ascites. I'm so glad you like it. All right, so feel free to DM me questions, comments, concerns. I hope you have a great week. I am glad that you liked it. Yeah, you can enter my email for any CASPA stuff. Whatever you want for CASPA, you can put my email. I'm glad you had fun. That's the point, guys. Make learning fun. That's how it sticks with you. That's how you learn and remember to, you know, do it in, like clinically in practice. So I'm so glad that you guys enjoyed it. I'll prepare a fun case study, I guess, next week again. Hopefully I'm not all crazy. I just get excited because I like that you guys are excited. So So I'm gonna head over and out. Have a great week. Remember, I'm here if you need anything. I'm glad you learned, and good luck to everybody. Even though you guys don't need it because y'all are so smart. Okay, show offs. Just kidding. All right, so proud of you guys. Alrighty, have fun. Good night. Bye.